the molecular features of the tumor can be integrated with tumor location, which we've increasingly recognized as an important biomarker that captures other aspects of the tumor biology that's not included in the standard gene mutation profiling efforts. The sidedness of the tumor has been shown to influence the sensitivity of the tumor to EGFR inhibitor treatments, especially in first-line administration.
There are differences between the right-sided tumor and the left-sided tumor. We know that based on even the embryonic origin, they are totally different. Typically, the transverse colon in the middle is sort of lumped to the right-sided tumor. We know that sidedness tumor is prognostic. A patient who have right-sided tumor tends to have poor prognosis compared to a patient with left-sided tumor, independent of the profiling, independent of the treatment. If you look at the phenotype, if you look at the sort of the molecular profiling of the left versus right, it is also different as well. If you look at the right-sided tumor, it tends to be more mucinous. It tends to be more poorly differentiated. It tends to be more MSI high patients. It tends to be more BRAF mutant patients. So these tells you right now is a little bit of a more of a poor prognosis. And the left-sided tumor, the tumor tends to have more of a HER2 amplification, especially in the rectal area. Tends to be a higher rate of HER2 amplification. There's a higher chance of being a RAS wild type. And there's also higher expression of epiregulin, which is a ligand that binds to EGFR. And we know that's one of the possible predictive marker to EGFR. So if you look at the profiling of left-sided, phenotypically, it looks like it responds better to EGFR inhibitor. So those are the sort of subtle differences between the left versus the right-sided tumor.
When we integrate the molecular features of the tumor and tumor sidedness, this helps us to improve our treatment option and selection for first-line therapy. The data suggests that in patients with RAS or BRAF mutated tumors or right-sided tumors, that these are tumors that do not respond well to anti-EGFR inhibition in combination with chemotherapy in first-line setting. There's some data developing suggesting the same for HER2 amplifications, that they don't respond as well to anti-EGFR therapy, although that still requires a few additional studies to really confirm before that will be included into the treatment guidelines. This sidedness information is increasingly important, and I think this has impacts not only for first-line chemotherapy combination use, which is where the most data is, but also thinking about what are the role for anti-EGFR therapies in second or later line treatments. In my practice, we'll commonly utilize an anti-EGFR therapy in first line in RAS/RAF wild type patients that are not HER2 amplified, that have left-sided tumors. And then we have long conversations about the wild type tumors from right-sided primaries, where may utilize EGFR therapy, but if we do, it's later in the disease course, third, fourth line, or beyond.